Good morning. I'm Adam Del Molino, Director of Virtual Care and Clinical Affairs, and on behalf of the Massachusetts Health and Hospital Association, welcome to today's webinar, Enterprise Virtual Care, Bending the Cost Curve of Chronic Care. A few logistics before we start today. We will be recording this session for those who aren't able to join us today, and all lines will be in listen-only mode. If you have any questions during the webinar, please enter them into the chat feature. The questions will come directly to us and we'll do our best to address as many as we can during our time today. Following the webinar, we'll be sending out the slides along with a brief survey. I want to take a moment to thank MHA's 2020 sponsors for their support in underwriting today's webinar, which is part of a series we're doing to bring experts to our members to help address timely issues relating to the COVID-19 pandemic. The Massachusetts Health and Hospital Association is proud to present a webinar series on hot topics in healthcare. In this webinar, you'll learn how a Florida ACO named CHC Pinellas, or CHCP, used enterprise virtual care to seamlessly scale care capacity for chronic care and patient support services without an additional budget, apps, or staff. We'll review how CHCP brought the concept of universal patient engagement to patient-centric care in order to drive significant outcomes. Our presenter today will show how CHCP achieved a 54% reduction in emergency department utilization, lowered overall patient costs by 26%, increased coding by 14%, achieved a 70% care quality gap closure, and more, while showing how the ACO increased reimbursements and exceeded its quality scoring. Now, I'm pleased to introduce our speaker today. Dr. Preet Garaya is Chief Operating Officer at Orb Health. He has over 15 years experience in healthcare operations and management, including multiple startups, and has deep expertise in telemedicine, clinical call center management, and revenue cycle management. Prior to Orb, Preet was Director of Revenue Cycle Management for South Coast Health, a premier New England health system, and oversaw the implementation of the Orb Health solution in his own organization. He was so impressed that he joined Orb Health to help drive the transformation of healthcare. Dr. Garaya, we're delighted to have you here today. And so without further ado, I will now hand it over to Dr. Preet Garaya.
Adam, thank you. I appreciate that. Big thanks to you, your team, and to the MHA for having us here today. As Adam mentioned, my name is Preet Garaya. I'm the COO of Orb Health. I'm an MD by education and by trade. I've been on the entrepreneurial and the business side of medicine for the past about 15 years or so. As Adam mentioned, I did implement Orb Health services back in 2015 and 16 at South Coast Health. And I'll go through those as to the process of chronic care management, how we implemented those, and what Orb Health brings to the table today to deliver on the things that Adam mentioned with decrease in ED utilization, care gap closure, as well as increasing patient engagement, and the decrease of the leakage for the health systems. So initially, I'd like to take this webinar through what is the main issue at hand, what are we trying to solve, and how we're solving that, and then some results at the end. Again, this will be based on chronic care management primarily, but obviously there will be some other aspects to how we deliver this service as well. So what's really the main problem today, right? With Medicare, we know that the population is increasing day by day, right? Currently, the estimates are about 133 million chronically ill population. That transfers over to the health centers trying to take care of this rising population, sicker population, more ill, with a decrease in budget, decreased FTEs. So they're trying to do more with less, right? That transfer over to the providers, increased stress on the providers, increased hours, increased documentation, more stress on the brick and mortars, Overall, there is just increased stress, whether it's on the health centers directly financially themselves and the providers, which leads to increased burnout. And then all of those three effects are the main customer here, which is the patient. The main problem with the patient is there is a lack of access in our healthcare today. So the patient, when they need the service at a timely basis, they are not able to receive that. Plus, there is a siloed effect. They do not know where to go to get that service. Do they call this number or do they call that? Which department? How is that care integrated together and there's collaboration? That's definitely missing. And a lot of times the patients don't realize a lot of these services are available to them, but again, they do not know how to access them. So overall, the main problem we're trying to solve is an access problem in healthcare, right? That's nothing new. Everybody involved in healthcare is well aware of that. So how do we solve for that? Some of the numbers at the bottom here, it shows 133 million chronically ill population and growing. 6 in 10 have multiple chronic diseases. And the main is 93% of the total Medicare spend is on these chronically ill population. So there has to be something done, something needs to be done in order to curb that cost. And that's where the chronic care management program comes into play. CMS back in 2015 made the chronic care management codes billable. And each year they've been adding more and more to that, whether it's transitions care management, PCP, principal care management, that differs from chronic care management where chronic CCM requires 2 or more chronic conditions to qualify. PCM qualifies only on a single chronically ill condition. And there's a myriad of conditions, and obviously there's other nuances to it to qualify, but there are multiple programs that CMS is putting into place to decrease that cost curve, to increase the access for the patients to be had. For this, Orb Health created an enterprise virtual care where Orb Health becomes an extension of the brick and mortar of the clients that we serve, and decreasing the stress on the brick and mortar practices, on the front end staff, on the providers themselves, and taking a lot of 95 to 98% of that on the Orb Health staff, on the Orb Health techs and the nurses to provide that care to the patients. Again, it's a extension of your practice. So just as anything would be done in the brick and mortar practice is how we train our staff to conduct that. In a second here, I'm going to go into the details of the chronic care management program as to how we do it. But first, just kind of going into the problem more so. The healthcare systems, a lot of them try to conduct these chronic cares themselves, but because we know these are very FTE heavy services, they either do not have the subject matter expertise, the FTEs themselves, the budgets to complete that. So a lot of times they try to instill a service where the existing nurses are asked to take on more and conduct these chronic care management services. And they never get off the ground. Either they have a 5 to 10% enrollment rate, and again, I'll go into it, their enrollments, there's nuances to that. So there's many reasons why a lot of the systems have tried to implement these services themselves and have not succeeded. Orb Health presents with a very encapsulated approach to this. We've created what is known as UPEC, Universal Patient Engagement Center. And through this engagement center, we can engage the patients, whether it is an administrative task or a clinical task. And the clinical tasks of chronic care management, TCM, PCM, all of those can be taken care of. We have specialized enrollment techs to enroll patients into these services. So our enrollment rates tend to be as high as 65 to 75% of the qualified patients. Or we can even do administrative tasks such as registrations, scheduling appointments, follow-up to COVID-19 positive patients, diagnostic comprehensive testing that needs to be followed up on. So again, this is more of a one-touch approach. If a patient is calling in to complete one task, we can definitely complete that task, but then see what other gaps exist and complete those. This is just a very high overlook into the Orb Health model. But for this webinar, I'm going to concentrate on the chronic care management piece and how that's conducted. I'm sure many of you, if not all of you, are aware that chronic care management is for those patients who have 2 or more chronic conditions and have seen their PCP in the past 12 months, is to keep those patients with chronically diagnosed with chronic conditions, to keep them stable, to keep them out of the ER, to keep them out of the OR, again, to decrease that cost curve. We know those visits are very costly, very expensive. So that's why these preventative programs have been put into place, that telephonically we can monitor the care of the patient and guide them forward. Let me give you guys an example. Let's say in January, a patient is seen by their PCP. They're diagnosed with 3 chronic conditions, let's say hyperthyroidism, hypocholesterolemia, as well as hypertension. And they've been prescribed 5 different drugs to take at various times of the day. Also a exercise regimen and a diet protocol. And they're asked to go into and get certain diagnostic testing done, and then come back and see the PCP in 6 months. Well, that's where a lot of the break in coverage happens. Then now this patient is kind of on their own in a silo to take care of all of these asks by the PCP that have been prescribed. Get the medications, take the medications on time, follow the exercise and the diet protocols, get the diagnostic testing completed, and then make an appointment and come back to see their PCP in 6 months. This is where a lot of the patients fall off the tracks that the PCP has set them on with the formulation of their care plan. So that's where the care delivery, the chronic care management program comes into play. That's where our techs and nurses, again, this is a white labeled program where there is no Orb Health post-contract. It's all going to be under the site that we contract with, the health system we sign with. We become an extension of your practice, and we reach out to the patients month after month to keep them stable on that track. Again, that's been set by the PCP. We do not diagnose, we do not treat, we push the care plan that's been set by the PCP forward, meaning reaching out to the patient. Are you taking your medications? Are there any side effects? Are there any new symptoms you're experiencing? If the medication is to be taken with food, do you have enough food to eat? Do you need a ride to the pharmacy? Do you need any care, or for diagnostic testing, do you need appointments? Let me help you set up that appointment. If there are exacerbations, triage them to, do they need to be seen by their PCP, or should we get them to go to an ER, call an ambulance, go to an urgent care, or monitor their symptoms, especially with COVID-19 these days, monitor their symptoms in-house and set them on a guideline how to follow those. So again, that's where the care delivery department of the chronic care management keeps these patients on track, provide a very holistic approach to keep them stable. So again, they do not end up in the ER or the OR for those costly visits, but keep them stable even though they have these chronically ill conditions. So with this program, obviously the direct impact is to the patient to keep them stable. But with this, there's a lot of ancillary benefits that come with it as well. When this relationship with the patient is built with month after month of telephonic care, they tend to then start to revert back to these Orb Health nurses. Again, there are no Orb Health nurses because it's white label, but they'll be calling the chronic care management number more so than the brick and mortar. They'll start to rely on the chronic care management nurses and asking for some of the administrative tasks. Hey, I need directions, I need an appointment. So that'll decrease the stress on the front end staff as well. Many will ask, how is the provider benefits from this? Well, the feedback we received from the providers is they feel, the docs, that we get a more complete coverage of our patient. Just like my previous example, they were seen in January, asked to complete this multiple step approach, medications, diagnostic testing, follow regimens, and then come back in 6 months. our nurses, they help keep them on the track and get them back into the office. It increases, or actually I should say decreases leakage. It increases that investment into the patient and that patient into um, um, the the health system itself. So it increases visits as well. So far, two of the ancillary effects of this program: it decreases leakage and increases face-to-face visits, and it decreases the stress on the front end staff. Then the patients, as I was saying, the providers, they have a more complete picture, because every monthly interaction that is taken place between the nursing staff and the CCM patient, all of that is documented directly into the EMR of the health system. There's a bidirectional interface that is built. It's synchronized to the EMR, so all the documentation ends up directly back into the EMR. So that is readily available for the provider to review prior to the next face-to-face visit, and they'll know exactly what transpired in the past 6 months. So again, when they go in for that 10, 15, or 30-minute time slot, they can concentrate on treating the conditions rather than focusing their valuable time on trying to get PHI for the previous 6 months. So again, with this virtual care management for the chronic care, we have a set enrollment department. Chronic care, CMS has strict guidelines on enrollment. There's 7 guidelines that need to be followed, and it's an opt-in program. Our success rate averages about 68% of the qualified patients in a 60-day campaign to get them enrolled. And then each month, about 85% of the enrolled patients are serviced. Again, this is a timely based minimum of 20 minutes of clinical care provided. And once we do that, all of that is documented, and the billing piece goes through the bidirectional interface. All of the CPT codes for this program go out just like any other CPT codes for your system. Just like any other CPT codes that are conducted by the provider, they will go through your revenue cycle. You will collect the compensation from those CPT codes, and then out of that, a fee is paid to Orb Health. So again, ROI positivity from day one. This slide, it shows the various administrative and clinical programs that Orb Health provides. Obviously, the very first one at top is the chronic care management, which we're dedicating this webinar to. But as I mentioned earlier, there's transitions of care management, principal care management, remote patient monitoring, behavioral health. But from the patient support, the administrative side, we increase the patient engagement, triage and appointment scheduling, registrations, follow-up on labs. We've been doing a lot of COVID-19 follow-ups, preventative screenings. So again, it's a holistic approach to keep the patient engaged with the health system and provide a holistic approach to their care to decrease the cost curve and increase the revenue. We increase revenue through increased face-to-face visits, through increased appointment scheduling, through decreased abandonment rate on the calls that are conducted by the patients coming into the UPEC center. So there's multiple ways of not only decreasing cost, but increasing revenue as well for the systems. Two of our customers, one is South Coast Health, as a lot of you might be aware of, in the Northeast, out of the south side of Massachusetts. I implemented the chronic care management services at South Coast myself. I'm a previous employee of South Coast Health, and this was back in 2016, and the program is going well. There's a 97% engagement rate at South Coast Health and continuation of patients month after month. At CHCP, Community Health Centers of Pinellas, this is one of the many FQHCs we work with down in Florida. We have a direct contract with healthcare networks, which consist of 58 health centers underneath them. And we work with many of those centers as well. Some of the studies, these are third-party studies that have validated the benefits of the chronic care management program as to what benefits this brings to the system, to the patient. As you can see here at the bottom left, third-party study conducted with our Florida clients showed a ED utilization decrease of 54%, which for them was an estimated savings of $6.2 million. As you can see, before the introduction of ORB with this patient population, over 1,800, almost 1,900 ED visits, and post-ORB for the same population, 855 visits. Now, with another study that's been conducted in Florida as well, not listed here, but that showed a decrease of 64%. And obviously, as we progress later on, and we can definitely share those studies and share some further results of that as well. Some of the decrease in cost for an ACO population, for the same population, again, prior to the enterprise virtual care implementation, the cost to take care of that ACO population was approximately 23 million. Same population, the following timeframe, 17 million. So annual savings of, again, about $6 million with these services. And it's not just the cost curve that decreases, but also there's an increase. This is a net increase of revenue with the call center utilization, the UPEC I was referring to, of a one-touch center, taking care of not only clinical but administrative calls, administrative duties, increase of revenue of 4.5 million. And many will ask, well, how is that done? That's done through better SLAs, decrease in abandonment rate, more visits scheduled, not only scheduling the visits, but conducting registration at the same time so the patient is ready to be seen, conducting appointment reminders, whether those are automated or through manual calls. So through these type of innovations and these type of services, increasing the revenue on that side. CCM, behavioral health fees for service. These are the CPT codes we just talked about. The chronic care management services we bring, almost a $10 million increase on revenue from that CPT code billing. And then TCM, transitions of care, transitional care management. We do have multiple models on that as well. One is the traditional fee for service on the TCM. Patients are seen within 14 days, seen by the PCP, and the code is dropped and collections from that. So almost a $20 million, little over $20 million increase in revenue. So again, two-pronged approach: decrease the cost, provide better care, and increase revenue for the system itself. The next slide shows from CMS the results that CMS is getting with various other vendors for the chronic care management is a 9% ED reduction rate. This is coming from CCM. Ours, obviously, as I shared with the third-party study, was a 54% decrease. Not only that, the time to achieve these improvements and these benefits is almost is half. The 54% reduction was in 9 months, as compared to the CMS, what they're reporting, 9% decrease, but it takes them twice as long, 18 months, to realize those benefits. So again, almost 6 times the impact in half the time. Again, that speaks to the 60-day enrollment campaign, getting over 65% of the patients that are qualified enrolled in this program, and then providing quality care. We have a separate compliance department that not only audits internal nurses, but make sure it keeps us on track for the external piece, meaning the CMS guidelines, to make sure we're following those on each call and on each chart. Proper documentation is conducted. So if there is an audit, we're able to support that audit with our documentation. So this is a service built upon quality and with number one customer in mind, which is the patient. We always teach our internal nurses that we focus in on the patient. If we take care of the patient, all of the financials, all of the logistics, all of the internal requirements will meet themselves. All of those will be taken care of if we take care of the patient. And that's exactly what our data is showing. If we take care of those quality care gaps, decrease those gaps, take care of the patient and provide them with the care that they deserve, the finances will definitely follow. And that's exactly what our clients are showing us. So at the end, initially we started with what the initial problem is. This is the outcome. The patients, they have increased access, they have the care when they need it and what care they need that's directly delivered to them. The providers, they're a decrease in stress, decrease in burnout because they have more help. They have an extension to help them with their patients, to take better care of their patients and to provide them, again, an extension of their services. Health centers, more than anything else, without the need of additional resources, FTEs were a full turnkey service. It provides them with, again, not only providing better care for their patients, decreasing the cost, increasing the revenue. It helps the health systems themselves. And Medicare, we're talking about the access problem. They're well aware of it. You all are well aware of it. And that's where Orb Health is helping as well, increasing the access to the patients so they can get that timely care. The last slide is just some positive feedback from some of our clients from the CHCP. Obviously, we have the clients in Massachusetts, in Florida, multiple clients in Florida, also in Georgia, Texas, New York, New Jersey, so all across the Midwest and East Coast. And obviously, we can share those more with the interested parties. So I will stop there. I appreciate your time, and I will open it up to for Adam to moderate the questions.
Great. Thank you so much, Dr. Garaya, for that really insightful overview of enterprise virtual care. Just a reminder to our audience, please put any questions that you may have into the chat box, and we'll get to as many questions as we can here in our limited time this morning. Briefly, we've already received a few questions, so I'm going to run them by you quickly here, Dr. Garaya. First question asks, for the patients who see many specialists and patients might have case management from their specialty's office, how do you get the patient to engage?
Sure. So that's our approach with the chronic care management and all of the other touches. It's not a call center approach. So it's not if the patient is calling that they're going to receive or reach one of 400, 700 techs and nurses that are working. We have a what's known as a care pod approach. So based on number of patients, based on number of sites, we assign care pods to each of those sites, locations at the health system. So for example, if a health system has, in New York, one of our health systems has over 40 PCP sites. So we'll assign, depending on the number of patients at each site, maybe one care pod or multiple care pods to each site, and each care pod consisting of anywhere from 3 to 6 nurses. So when those patients that are assigned to those care pods, they'll build a relationship with those nurses only. So when they call in, they'll only speak to one of those 3 to 5 nurses. So that increases the engagement between our nurses and our staff and the patient themselves. So it's easier and more readily we can take care of their needs, whether it's with the multiple docs they're seeing or it's only the PCP. The chronic care management is kind of the foundation of this, where we build upon the PCP's care plan they've set. But then after that, we help navigate all of those touch points, whether those are specialties, diagnostic testing, preventative care needed, appointments needed. We help navigate all of that through that approach.
Great, thank you very much. Our next question comes in. How do you get buy-in from the medical providers, specifically the primary care providers, who do not think their patients need care management because they believe their patients' medical conditions are stable?
Yep. That is a question that comes from all of our clients. When we contract with a client, majority of the providers They do see the need for this when we go in and actually explain that this is not just a one single phone call, but it's a holistic approach. And they know that our resources are limited and we provide additional resources on their behalf. Again, we don't diagnose or treat. We just push that care plan forward and keep their patients on track, keep them more engaged with that care. Even if they are stable at the time, we know that patients that are diagnosed with with chronic conditions are more likely to have an exacerbation, more likely to end up in the ER, more likely to end up with some sort of acute event. So this care is definitely needed. They might be stable, but that's the end goal, to keep them stable. We aid in that process, not hinder or add any extra stress or work to them. So once that's explained and we're able to show our results to them, we're able to be very transparent and keep them involved with the care of their patient, not work in a silo on an island, they tend to realize. And in full transparency, there's been times where certain sites, it takes them a month or two, certain providers, it takes them a month or two to realize, okay, this program is working. This program is definitely something that we needed. So from the get-go, then all of them might not be on board, but once they see the results, once they see how happy their patients are and they get the feedback from their patients, they all tend to buy in and see that this service is definitely needed.
Great, thank you. Our next question coming in, are the nurses providing coding information to the provider for the HCC codes not previously used? And what is SLA?
Sure. So two things. One, with the HCC approach, for the chronic care management program itself, no, because that's a separate program. But remember, as I mentioned with our UPEC, we have multiple programs that can be incorporated together. So some of our clients have asked that they do need help with HCC scoring. That gap needs to be closed, and they need to make sure that the severity of their population needs to be relayed to Medicare. So again, they can be properly compensated. So we've organized programs for those clients to make sure that, number one, all of the previous, because as you guys know, with HCC, on January 1st, Medicare thinks all the population is fully healthy. So each year that has to be redocumented. So through our CarePod approach, a patient is more likely to open up. Let me give an example. So let's say if somebody has diabetes, 3 years ago, there was an amputation of the left toe. If there are no residuals from that amputation, neither the physician nor the patient is going to bring that up. But if our nurses are aware of that, they'll make a little documentation note in the EMR. So the next time the physician is seeing that patient, they can ask about that, quickly make a note of that. At least now it's documented, and now it can be coded appropriately. So we do help with that approach of the HCC. The second piece of that, first is to document, second is for the coding piece. So yes, we have done, whether those are lookbacks or created some workflows and processes with our centers to have some sort of flag or some sort of indication that there needs to be a coding review of this. We've done coding reviews as well. We work with rev cycle departments and coding departments to conduct those. So we can definitely form programs around that. But again, the chronic care management is the basis that in order to identify those previous conditions that might not pop up or might not be properly appropriately documented, to document those and then conduct the remaining half. So long-winded answer, but the high-level answer is yes, we can aid in both parts of that, documenting and coding identification.
Great, thank you. Next question coming in asks, do you have some suggestions for panel sizes and how many patients per registered nurse case manager, excuse me?
Of course. For each of our care pods, we assign no more than 250 enrolled patients to be taken care of for the chronic care management program. It differs depending on the type of population, the demographics, but we tend to range anywhere between 180 to 250. And that's where we base our care pods off of.
Okay, next question coming in says, your enterprise virtual care depiction had a virtual care cloud and the UPEC. What does the virtual care cloud do?
Yes, virtual care cloud is the intelligence in the background. It's the functionalities of a call center with the intelligence of our Orb Health platform intermingled together. So for example, if a patient is calling in, not only is the phone number identified, but also their medical information is popped up, so then care gaps can be closed. Let me give an example. Let's say a patient is calling in because they just want to schedule an appointment. Well, our virtual care, it is intelligent enough that it will identify the gaps as to there are clinical gaps, there are diagnostic testing that was prescribed but not completed yet. That will pop up as well. So as soon as we have conducted the initial request of scheduling an appointment, then our techs and nurses can hit upon those open items as well and make sure that's completed. So UPEC is the collaborative service that is offered, the patient engagement center. I cringe to call it a call center because we're dealing with patients. We're not a call center. We're an engagement center where we do have to engage with the patient and treat them so. So that's the difference between UPEC and the intelligence, the virtual care will be provided in the background as to it's intelligent enough to identify those gaps, and then we can take action on it.
So one other question comes in and it kind of flows into your response that you just gave. It said, are you just a call center or more? How does collaboration with the primary care physicians work?
Yep, we are much, much more. The call center, again, I tend to shy away from that. It's a patient engagement center. Under that patient engagement center, we can conduct various types of services. One of the main ones of those services is the chronic care management program. So in that chronic care management program, the back and forth with a PCP, so for the chronic care management program itself, 95 to 97% of the workload is on us. We're a turnkey service. The only time when we reach out to the PCP is when those workflows have been identified in implementation as to, is there an exacerbation? Is there a change of medication? Is there a diagnosis or treatment needed? Wherever there is, again, diagnosis and treatment, we don't do. Whenever there is a need of a PCP input, and again, that would be, all that protocol will be decided well ahead of time during implementation, only then do we follow the protocol and get the PCP involved. That involvement can be done through the EMR, a messaging through EMR. It can be a text message. It can be an email. So it's all dependent on what the client's needs are and how they want us to interact with them.
Okay, we're going to just take two more questions here since we're far beyond where we were for time. First question coming in asks, how do you handle patients who want to disenroll due to having a copay?
Yep, very good question. So there's two-pronged approach. Some of our clients have decided that the benefits of this program vastly outweigh the copay that they would try to collect. So they have made it a system policy not to collect on certain CPT codes. And then the second is ones that have not decided that, there is a proper explanation that goes into it. Our nurses and our techs are trained, so they are able to explain the explanation of benefits and what goes into it, and to say that patient responsibility, what benefits they're going to get out of it. So it's a very transparent approach with the patient, so they understand what exactly is they're going to be getting from this $8 and change for chronic care management fee, if there is a fee. But again, majority of our clients, they understand the benefits vastly outweigh the $8 copay, so they tend to just go ahead and write those off systematically.
Okay, great. Our final question today comes in and asks, are you using the LPN or LVNs and certified medical assistants to complete the MIPS quality measures? You do not hire RNs. Who actually is developing the care plans?
The care plans, obviously the initial one is conducted by the PCP. Then on our staff, we have LVNs, LPNs, and RNs, and we also have some MDs in certain executive roles to make sure that everything is being conducted according to the guidelines. Those care plans are conducted by RNs. That is the guidelines by CMS. So we are following all of those and staying compliant, and the RNs are conducting those. Adam? Did I drop off?
Oh, it looks like Adam may have dropped off.
I believe so.
Oh, nope, sorry, I'm right here. I'm right here. Sorry about that. I'll just close it out. Thank you very much. That was really highly informative, and thank you all for attending. Please check out our website for more information on upcoming virtual events and webinars. We will be sending out an evaluation which will ask about additional topics you would like to hear more on. Thank you very much once again for joining us, and have a great day.
Thank you, everyone. Thank you, MHA.